Hello and welcome, everyone. Thank you for being here today. My name is Autumn Hume. I am the account director with MDA's Healthcare Partnerships team. And thank you so much for joining this industry update webinar sponsored by Scholar Rock entitled Clinical Studies in SMA, a Clinician Perspective. On behalf of MDA, we would also like to thank you for all you do for the MDA and the neuromuscular community. MDA's Industry Update webinars are programs which provide an opportunity for the medical community to receive information and updates impacting care and treatment directly from pharmaceutical and biotechnology companies. These webinars are just a part of MDA's medical education resources. We encourage you to visit the medical education pages of mda.org. You will find resources such as considerations for care case studies, recorded grand rounds webinars, research grants, and so much more. Now I would like to introduce our presenter today, Dr. Leslie Nelson, PT, PhD. Dr. Nelson is a physical therapist serving as assistant professor in the Department of Physical Therapy at the University of Texas Southwestern in Dallas, Texas. She has a broad background in physical therapy practice with a focus over the last 20 years on infants, children, and adults with neuromuscular disorders, including SMA. In addition to her clinical expertise, she has been involved as a consultant and clinical evaluator for both investigator-initiated grants and industry-sponsored clinical trials for studies involving various neuromuscular disorders. Leslie enjoys the opportunity to educate patients, families, and other therapists on topics including outcome measures, exercise, and therapies for patients with SMA and other neuromuscular diseases. Now, without further ado, I would like to turn it over to Dr. Leslie Nelson. The floor is yours.
Thank you, Autumn. I appreciate it. I'm so thankful to have the opportunity to present some of this information today. So thank you for being here. I look forward to answering any questions that you all may have as well. To cover just a few disclosures, please know this webinar does contain non-CME content. This Industry Updates webinar is sponsored by Scholar Rock, and I am speaking on behalf of Scholar Rock and did receive honoraria for my participation with this. And thank you all to those that helped prepare this presentation as well. So I think we are in such an exciting time in regards of neuromuscular disease in general, but also, of course, as you all know, in SMA and newly developed and approved therapies that we are now able to use for this patient population. And while it's exciting, we're seeing changes in how these patients are progressing. And I think the reason being is, of course, we have our patients who can be treated with SMN therapy drugs, in a sense, that are helping provide SMN protein to these patients. But we also have our non-SMN therapies that are in the pipeline and coming to us. And so the way that our patients are responding as compared to untreated patients, we really are looking at outcomes in a different way. And so I'm excited to talk to you a little bit about how we monitor change in a way that we didn't have some of the challenges that we have new challenges that we didn't used to have in our untreated patients. And so as that SMN protein is being produced along with potential non-SMN therapies, strength gains are happening, changes in how our patients are presenting from a standpoint of contractures or scoliosis are also things that we consider. And so those are the things when we assess patients and motor function, we keep in mind. As far as how often screening is conducted in relation to functional outcomes, in general, there has been reference to the fact that examinations of patients should occur every 6 months, including motor function. And it really does need to be motor function according to an appropriate scale for that particular patient. Additionally, there are patient-reported outcome measures that can give us very valuable information about quality of life. And I think those are things that we need to not forget. I myself am sometimes biased as a physical therapist, where I'm so focused on motor function and seeing where they fall on a developmental scale or where they fall with particular gross motor function or fine motor function. And I have to remind myself that it's really important to incorporate their values, their goals as a patient in order to assess how they're feeling about their progress. When we think about which scales to use, of course, using a patient's age as a determinant of validation of the scale and if it's appropriate is one consideration. Additionally, with what features of the assessment are available, are we really wanting to look more at fine motor? Are we wanting to look more at gross motor or a combination thereof? Do we want to look at core kind of axial types of strength or transitional types of movement? All of those things are important to consider depending on what may be included within a standardized assessment. And then what is the target patient population, and or was the test that we're using actually validated for SMA? And we'll talk a little bit about when it's appropriate to use something that maybe is not specifically validated for SMA. When putting together this set of slides for this talk, we really put together a nice comprehensive list of the current motor assessment scales that I think are most commonly used in clinical practice. And so I mentioned that SMA validated assessments. That includes CHOP Intend, the revised upper limb module, the Hammersmith expanded, the revised Hammersmith, the motor function measure, both the 20 and 32, a 6-minute walk test, an assisted 6-minute cycle test, the CHOP A10, and then the neuromuscular GROW. Then we're also, as I mentioned, sometimes using norm reference scales that were not specifically validated for SMA specifically, but can be very beneficial in helping us assess the progress along the continuum of motor function development. The Heine or Hein neuromuscular evaluation, the Bailey scale of development, there's versions 3 and 4. We'll talk a little bit about those. The Peabody developmental motor scale, and then the Ames, the Alberta infant motor scale as well. And I think those are probably the most commonly used assessments that I'm seeing in clinical practice across the US and even into Europe in how we are assessing our patients with SMA. And like I mentioned, we're in such an exciting time where with Newborn Screen, we're now able to identify our patients early before they have clinical symptoms potentially of SMA. And we know that when we have treatments that impact the SMN protein and otherwise, the earlier those are given to our patients, the better outcomes they have. And so it's really exciting for me to be able to see an infant in clinic, and I can assess the CHOP Intend, which was developed for neuromuscular diseases in infants that are very weak. And really, in general, the items on the CHOP Intend ceiling out at about 4 months of development. And so I am loving being able to see our patients with SMA who come back in for their 6-month follow-up at 6 months of age after being seen at a newborn screen visit, and they've already ceilinged out on the CHOP Intend. And so it's no longer useful for us, which is a great problem to have. And so therefore, we're starting to utilize more norm reference scales, and those are becoming more important to be able to track change over time. So as I mentioned, while the CHOP Intend has no real set lower or upper age limit, and honestly, for a while, when we first started having commercial treatments available for our adults that were being treated with SMN therapy drugs, we were using the CHOP Intend even in older patients. While it has some items that assess reflexes, you can still use active movement and still score some of those items on the CHOP Intend. But it's much more difficult and actually is a lot harder to apply to a function in a patient that is someone who does not sit. So it really does target those weaker patients who are unable to sit unsupported. It does do a nice job of assessing axial and peripheral muscles and looking at things like rolling, movement against gravity in the limbs, both upper and lower extremity, head control, those types of things. And so it does have some nice items. The other thing is, of course, while it is an infant scale, We used behavior state to identify cooperation, for lack of a better word, in infants. And so there's an ideal state of where a child is not um, is content, well fed, and awake. And so ultimately, that's the best time to assess this scale. But we can consider some movement when they're not within that behavior state as well. And then the Hammersmith infant neuromuscular scale does have an age range of 2 to 24 months of age, but it can be used in function of patients who are developmentally progressing from non-sitting to sitting to walking. So it does assess gross motor function into the walking stages. And the thing that you're tracking is looking at motor milestones as well as the impact of cranial nerves, posture, tone, and reflexes. And so it does go hand in hand well with your physiologic motor development, kind of your WHO motor milestones, but gives you a nice categorical type of a scale to be able to track those developmental milestones. So we have infant-based scales of the chop and tend and the Heine, and then we move into more of a toddler age, and that is where you'll find that the Bailey 3 and now the Bailey 4, which are norm reference scales that are being utilized in clinics in order to monitor gross motor and fine motor development. The other thing that actually is not on this scale that I'll tell you is that they also have components of language as well as cognition. The difference between the Bailey 3 and the Bailey 4 was put out maybe about a year ago or so, and it's an updated version of the Bailey 3 and it uses a different source for their norm values. It's also using a scoring system of a 0, 1, or 2 scale versus a 0 or 1 scale on the Bailey 3. So on the Bailey 3, it was either they were able to complete the task or not, where there is a little bit more sensitivity with the Bailey 4. The Bailey 4 in general also takes a little bit less time to complete the items from the way that it's set out, because it does have fewer items within each section. And again, like I mentioned, that addition of the potential scoring of a 0, 1, or 2 does increase its sensitivity a bit more. And I do think the Bailey 4 is becoming more frequently used in clinics. I think those that still use the Bailey 3, and I'll tell you that we in our clinic are biased to the Bailey 3, and it was mainly for a couple of reasons. We started the Bailey 3 early on in our patients, newborn screen patients, because that was the scale that was available. The Bailey 4 was not available yet. And additionally, the Bailey 3 is the scale that was used in some of the clinical trials that looked at our patients with SMA from in infancy and beyond. And so I think that is where a lot of potential clinics are still using the Bailey 3. But I do know that switching to the Bailey 4, there's a couple of things that you do have to purchase the kit and the scoring criteria from Pearson in order to transfer over. And that was another reason, for a sense of staying with the Bailey 3 for a while. I will say, though, that our clinic is now transitioning to the Bailey 4 for the reasons why it's a little bit less time consuming and a little bit more sensitive. The Peabody Developmental Motor Scale is, and actually there is now also an updated version 3 of the Peabody as well. But the norm reference scale is a scale that actually can go a little bit older than the Bailey. The Bailey goes up to 42 months, so 3 years, whereas the Peabody can track gross motor function in older children up to 5 years of age. So I think that's where the benefit of using the Peabody is. You can use this to track these children a little bit longer. There is also a fine motor and gross motor component, just like the Bailey, but it gives you a total motor index as well so that you can combine both fine and gross motor skills. So it is another nice option that clinics can use to look at gross motor development and fine motor development. And then I'll tell you the other quite commonly used infant scale is the AIMS, the Alberta Infant Motor Scale. And so it will assess gross motor function in children that are less than 18 months of age. So obviously it doesn't track into the older years, such as the Peabody, but it is a nice scale that is very reliable and valid for our patients. And it's something that I think a lot of clinics are using, and especially in those newborn screen children, in order to monitor gross motor function, and can be a fairly simple scale to use to track those gross motor items in an effective way. So this is just a nice chart that looks at a comparison of all of those scales that I've mentioned. Again, age-wise, I kind of pointed out the biggest differences there. The Ames is up to 18 months, Peabody up to 5 years, Bailey 3 and 4 up to 42 months, the Heine around up to 24 months. And then Chopatind, I mentioned really no limit on age. We do use that up into our adult non-sitter patients. But we'll talk a little bit later on about some newly developed scales that are potential uses for your weaker patients that are non-sitters. Again, I think all of these measure well, both axial as well as peripheral gross motor function, those kinds of fine motor function. And so the thinking about what you really want to track in your patient is where I would consider making your decision on which one is best for your clinic. And then also time components, equipment components of what makes most sense to be most effective within your clinic setting. Now, for infantile outcomes and for non-sitters, we've talked a little bit. Now we're going to move into what options do we have for treating our patients that are sitters or walkers. And the Hammersmith expanded and motor function measures are validated scales that are used in SMA that are quite commonly used in our clinic setting. They are both, including the revised upper limb, which we'll talk about a little bit as well, effective, easy to administer, easy to score, with a sense of understanding the administration and the standardization of kind of knowing the scoring configurations as well. But they are the options that we have for our patients that are sitters and walkers. So the expanded Hammersmith Functional Motor Scale is a scale that had used the original Hammersmith scale and then added on 13 items from the gross motor function measure, which is a scale that was developed originally for patients with CP. But what we found was the original Hammersmith had a ceiling effect. It really was not able to capture those stronger patients that were ambulatory. And so adding some of the GMFM items were better able to capture stronger ambulatory patients. So it is validated in sitters and walkers with SMA at 2 years of age and older. It's a little challenging to administer in a 2-year-old, but it can definitely be done in a more observational fashion rather than a standardized fashion in a 2-year-old. And I would say around 3 is when I start to see better ability of a child to truly follow directions in order to get a more standardized score, but still validated in 2 and up. It is scored on a scale of saying they are either unable to complete a task, they complete a task, but they do so with some sort of modification or adaptation, or a 2 full score would be that they're able to complete the task without any modification. The revised Hammersmith is another scale that's being used more and more, and it includes items from the expanded Hammersmith, but then also has timed function tests, such as a time to run 10 meters and a time to rise from floor, which can be very, very helpful and more sensitive in looking at these patients. And then the motor function measure 32, which was the original scale, and then the 20, which was developed for patients that were 2 to 7 years of age, if I remember correctly, are scales that are used that have 3 domains. And so you can look at axial or kind of proximal types of items, gross motor items, and then fine motor items. And so it is a nice scale that incorporates both gross motor and fine motor. It does take specialized training in order to be certified, but there are some modules online that you can use. And then the 6-minute walk test for our ambulatory patients is a very important skill that can really look at endurance. The nice thing about doing a standardized 6-minute walk test is if you do minute splits, you can actually calculate the percent fatigue. And so it's a nice way to kind of look at not only cumulative distance, but also differences in time from the first minute to the last minute. And it really does capture fatigability in our patients. And then the revised upper limb module is an assessment that looks at upper limb function and fine motor function. It was developed specifically for SMA. And so there are a lot of similar items on the revised upper limb that were on the MFM, the motor function measure as well. The thing I love about the revised upper limb module, though, is that it takes into consideration contractures. And so patients are not limited in their score because they might have a contracture. And so it makes it a really nice scale to use. And again, this is a nice chart that just goes over those items. If you're looking for a combination of both fine motor and gross motor, an axial MFM 32 and 20 are an option. Combined Hammersmith or revised Hammersmith and ROLM is another option. It's what we do in our clinic. And then the 6-minute walk as well to look at endurance rather than strength. And then I mentioned a little bit earlier, we were initially using the CHOP intent for non-sitter adults. But as we've started to see that really the sensitivity there is difficult, it's difficult to transfer them out of their chair in order to do the intent. And so we're starting to see new skills that are being validated and developed. And the first one I'll talk about is the CHOP A10, which is available you can look on the Stanford website. They have a manual that takes you through how to use this scale and score this scale. It's in validation currently. We have a few publications to look at its use. It does seem to be feasible. It does seem to be reliable. It does seem to be a good option for our weaker patients to look at fine motor and gross motor strength. And then the neuromuscular GROW is a scale that was developed out of Nationwide. And there is also an emerging assessment that's being used that looks at motor development, includes all ages and all functional ranges. So you can use this in your non-sitters, sitters, and walkers, and is also in validation as well. And then I think lastly, from a standpoint of endurance, I mentioned the 6-minute walk test for our ambulatory patients, but we're working on finding validation in our 6-minute cycle test using an assisted upper extremity bike. And I find that we are seeing this as promising as well to start to look at endurance in non-ambulatory patients. So these are our newly developed skills in kind of the process of being developed. So in conclusion, I hope that I've given you a nice summary of the potential options you can use, where you might use function, age, different needs depending on the patient, of whether or not you want to look at gross motor, fine motor, axial movement, and having a decision-making kind of algorithm on what scale is best. Mentioned briefly kind of reasons why there may be some limitations. For instance, the N10, it's hard to get someone out of a chair. They're too large to look at reflexes, those kinds of things. But giving you some options that you can use in different situations. And hopefully, again, this is something that will help as you continue to improve your care and your disease management of your patients. So with that being said, I hope I've not gone too much over time, but I hope have allowed some time that I can answer some questions. Here is just another kind of list of all of those skills. I'm happy to either leave that up. I don't know if Chris, or I don't know if you think I should leave that up or if I should stop sharing so I can, I don't know if I can see anyone or not, so.
I think it makes sense to leave that up to help potentially prompt questions.
Sure.
And if you have any questions out there, please go ahead and put them into the little Q&A box, and we will do our best to get them answered. And so let's see. Okay, so the first question that I see is, How would you choose as a clinician between MFM and HFMSE in clinical practice?
Sure. I think it's a really great question. It's one I get asked often, and I'll answer transparently. I have bias because of what I was trained to use and I've always used. I personally use the HFMSE for my sitters and walkers in clinic. I do think that I'll take that back. We've transitioned to where for data purposes, we're kind of tracking HFMSE and revised Hammersmith at this time. The reason why I feel like we transition more to the revised Hammersmith is to capture those timed function measures, the 10-meter walk run and the timed up from floor. But what I will tell you is if you're someone who's been using the Hammersmith expanded and you don't want to transfer using to the RHS, just add the timed test, timed 10-meter walk run and the timed up from floor to your Hammersmith expanded. And I think that's an easy kind of fix in the sense of I kind of expanded on your question a little bit and added the RHS in there. But that's how I would kind of address that potential limitation of the expanded. Now, when you compare that to the MFM, the thing that I'm very lucky in my clinic is that I have the equipment, the space, and I really am typically afforded the time to do both the HFMSE or RHS and the ROM so that I can capture both gross motor and fine motor function. And that's what I feel is best for how I can track my patients. If doing both the revised upper limb and the Hammersmith from a standpoint of wanting to know gross motor and fine motor, then that's when the MFM can be nice to be used because it does capture some fine motor, some distal upper extremity items that the expanded Hammersmith does not. So I guess that's kind of a long answer to the question in that if you want to capture both fine motor, upper extremity, and gross motor, lower extremity in one scale, your MFM 32 is a nice way to do that. The MFM 32 you do need to be trained or to have some sort of understanding of kind of the standardization of the scale and the scoring. And additionally, there is a kit as well for that item for that scale that you do need to be able to provide to do that in a standardized way. The other thing I think that from the MFM standpoint is that if you understand the scoring a little bit better, someone with scoliosis or contractures on the MFM, there's a few items on that scale that they'll never score the best or the highest score because contractures are present. And so that can sometimes be a limitation, in my opinion, of using the MFM and SMA. Oh, Autumn, I think you're muted. Sorry.
Thank you.
Yeah.
Okay, so thanks. Another question that we have that came in. Do you know what outcome measures Medicare requires for adult patients receiving Spinraza injections?
Yeah, that's a really great question in a sense of I guess the way I'll answer this is I do not know from a standpoint of the required outcomes. What I will tell you is that in my experience, in my adult patients that are on Medicare receiving medications, I have started to submit the ATEND in those weaker patients, in the adult patients, and I've had no denials. I will also say that in general, so that's in response to if, let's say, they had asked for the intend. I'm not having any issues with that. From a standpoint of actual required, I think out of just my clinical bias, I've always done the Hammersmith expanded and the revised upper limb, and again, have never had any denials in that respect either. It's even with the really, really weak patients that don't have much function. So that's how I would answer that. But I can't tell you that I know for sure the actual Medicare requirements for those patients. You did say Medicare, not Medicaid, right? Oh, You're muted again.
Sorry, gosh, I
No,
should
no,
stop muting.
that's okay.
Um, yes, it was Medicare.
Yeah, yeah.
Great. Okay, another question that came in. Which of these assessments require special training and where can you get the training?
Yeah, great question. So I will say the MFM 20 or 30 and 32 is the only scale that really has a certified training program. There is a website for the MFM that you can go to find out more information on how that can happen. There are 3 trainers in the US that are certified to do official training for the MFM. But there is some there. If you'll look at the website, you'll see just more information there. The A10 I mentioned has a manual on the Stanford. It's John Day's website, neuromuscular website, that does have an A10 option that you can go to. And the manual is uploaded onto that, as well as a training video, which you can watch and get some information on how to assess that scale. The, let's see, the Hammersmith, the ROM, and the RHS, as well as the Chop and Tend, those do not have any official training websites. They all have manuals that are used as standard practice. The one place I know that you can get all 3 of those is actually on a website that's called StepIn, STEPIN. You can go to the resources tab on that website, and they have all of the manuals listed there. So those are the places that I know are free access to all of those manuals. And the assisted 6-minute cycle test really, again, is in validation. We don't have any formal manuals for that. And then I think that's all of the, and I'll be completely transparent. I do not know if there is an official training site for the neuromuscular grow. I don't personally use that scale, and so I've not looked into the training much for it. So I apologize that I don't have more information on that one for you guys.
A few more questions still. So, one, we have struggled with our patients that are weaker. We like the proposed scale for patients with very low score on CHOP and TEND by Pierschlewitz et al. Do you happen to know if this is being moved forward to validation?
Oh, I wish I knew what the name of that scale was, because I don't know the name of that author. So I'm not sure.
Yeah, and I probably did not pronounce it correctly, so that
Yeah, no, that's okay. I would
might not
honestly
have
have
helped.
No, I'd honestly have to do a really quick search to see if I could find out what that scale is.
Okay. Well,
I
maybe we can
apologize.
try and get back to that person. And
Yeah,
then another,
if you want to, sorry, Autumn, I was going to
go
say,
ahead.
if you don't mind seeing, like, tracking who that is, I'm happy to have an email conversation with them if that would be helpful. Because I mean, I also would love to learn from them what they're finding. So that'd be great.
Great. I will
Sorry.
make of that. No problem. Thank you.
Thanks.
And then another one, I know you've discussed adults, but have you used the attend with adolescents who are weaker and difficult to transfer and have been
Yeah.
able to use this for authorizations for Spinraza?
Yeah. Great question. The answer is yes. We use it in our pediatric clinic here in Dallas. And so I've used it on our weaker, yes, adolescent, early child, or later childhood types of patients that really it's just too much to transfer patients that are trached and vented, those kinds of things. But it has been a really nice scale. It's still sensitive enough that we're seeing changes. And so what I'll be honest, what I typically do in those children and adolescents is the items are similar enough to the intend that I can informally score an intend when I do the ATEND. And so I'll submit and I'll say, and I'll report to in my note, my objective, I'll say that they scored a 0 on the CHOP intend, or what, maybe it's a 1 or a 2 on the intend, depending what it is. But then also put my ATEND score. So I'm not taking extra time to do both scales, but I'm utilizing the ATEND assessment and filling out my intend score. So that's how I kind of manage that. If I have any kind of denial or need a peer-to-peer kind of thing for those patients that are children or adolescents.
Perfect. And I think I see one more question, and it is a perfect one for us to close with. So, what are your hopes for the future of clinical scales?
Wow, it is a great question. Like I said, it's so great that we are in this area of new natural history, really, and how we're kind of looking at how our patients are responding to treatments and more, with our myostatin inhibitors coming and those kinds of things. I mean, we're just going to see what I foresee is I really hope to see where starting to look at true strength changes, rather than just general gross motor function and functional measures become more and more important, to really see changes over time. I think we're in a good place in the sense that what we have is a really nice uh, base for what we need to know. But again, I think moving forward, I hope that we're wanting to look more and more into advanced ages and seeing kind of how I think endurance and fatigue are probably the areas in SMA where I hope that we start to advance a little bit more. And I think that's where 6-minute cycle tests and some other endurance types of things could be helpful. The other thing I'll tell you is that finding a quality of life PROs that we mentioned briefly at the very beginning of this talk, but I feel like that's where we can see some things. And then the last thing I'll say that I didn't really talk about at all is the potential, but I do think this goes hand in hand with the endurance, is potential of using wearable devices to capture endurance, motor function, general just overall mobility, could be an area where I see a lot of our future heading. So that's exciting.
That is exciting. I agree. Um, I have just a quick closing remark, but we have one question that's asking if you could put the table with the Bailey and Ames up again, please.
Sure.
So maybe if you
Oops.
want to do that, and I will close
Sure.
us out. But just a reminder to everyone who attended today, this has been recorded and it will be available on MDA's medical education page for future on-demand viewing.
This table, I'm assuming.
And perfect. Great. Thank you so much. And just great information shared today. So thank you, Leslie, and to Scholar Rock for the insightful presentation. And thank you to our medical professionals who attended today's program. We hope you will join us for future industry update webinars and other medical education programs at MDA, as well as at our upcoming MDA Clinical and Scientific Conference in Dallas. So I hope everyone has a great rest of your day and a healthy, safe, and happy holiday season. So thank you, everyone. Take care. Bye-bye.
Thank you.